Okay, dear everyone, thank you for joining. On behalf of the European Society of Endocrinology and its Early Career Committee, EISE, I would like to welcome you to these highly anticipated ESE talks focusing on male reproductive health. This webinar is a collaborative effort between the European Society of Endocrinology and the European Menopause and Andropause Society, and it builds on the success we had with the female reproductive health webinars back in April this year. I'm Kristina Saravinovska. I'm an MD and PhD candidate at the University Clinical Center of Serbia. I'm also a board member of the EISE committee, and I'm a leader of the EISE observership programs. And today, I have the greatest pleasure to co-chair this event with Elena Armeni from the EMAS board. And when we were actually designing this webinar, our initial idea and aim was to shed light on the critical issues on male health overall. So as we know, male reproductive health is not only integral to fertility, but it also affects males' overall well-being and mental health. And we are very proud and honored to have 6 leading experts that will spotlight some of the critical topics in this field. So with this, I would like to thank you and for joining, and I would like to pass the virtual stage to my co-chair, Elena Armeni.
Thank you, Kristina. Hello, everyone. I would like to welcome all of you today in this very beautiful project, which actually starts looking exactly as Kristina and I have envisioned when originally the discussion started taking place about testosterone. Who am I? My name is Elena Armeni, and I am a consultant endocrinologist in London and also honorary assistant professor at the University of Birmingham, UK. My base academically and emotionally is and will always be Greece. So as an elected board member, treasurer, I have been working on behalf of the early career members of the European Menopause and Andropause Society with EISE. And I want also to greet and thank all of the participants who are leaders on their field for the fact that they have managed to take time to be here with us today. But why testosterone? I heard recently something I wanted to share with you. Testosterone replacement and the treatment of hypogonadism is nowadays where menopause was 20 years ago. So this is an emerging field. All of us need to be aware about how to manage the man that comes to the clinic and what issues we need to pay attention to, and try to organize the management at a way that both ourselves and the patient will benefit. Very last word from my side is the fact that this webinar very nicely builds up on the guidelines that were produced by the European Menopause and Andropause Society last year and endorsed by the European Society of Endocrinology. So this is step 2 of the work on testosterone, and I hope many more steps to follow. With regards to practicalities for the day, I would like to invite all of you to share your questions with the panelists using Q&A, which is on the lower hand side of your screen. Kristina and I will go through the questions. If something is very easy or practical, we will address on the spot, but the best questions we will select for the Q&A session at the end of the presentations. And Kristina, back to you. I think it's time to announce the presentation of our first speaker.
Thank you, Elena. So with this, we are officially opening the ESE Talks Men Up, a guide to male reproductive webinar health. And our first speaker is Walter Vena. Dr. Vena graduated in medical school at Sapienza University of Rome with a thesis project on testosterone replacement therapy and completed endocrinology and metabolism disorders residency at University of Milano with a thesis on Klinefelter syndrome metabolic complications. Currently, he is working as a research assistant at the Humanitas University and is focusing his research activity on male hypogonadism, testosterone replacement, and consequences of hormonal deprivation. Dr. Vena is co-chair of the EISE committee and representative of Italian Andrology and Sexual Medicine Society, SIAM's Young Branch, Andrew Young. Dr. Vena, the floor is yours.
Thanks, Kristina, and thanks, Eleni. Before I begin, I really want to thank everyone for the organization and for inviting me to this beautiful opportunity. I will talk about male obesity and secondary hypogonadism. And I'm really thankful again to the organization, to the European Society of Endocrinology, and to EMAS for allowing me to be here today in this beautiful webinar. And before that, I really need to thank SIAM's, Italian Society of Andrology and Sexual Medicine, and their young representative, Andrew Young, which has really been, scientifically speaking, my first home. And they gave me the andrological, endocrinological background that allows me to be here today speaking to you. And so we can start. Male hypogonadism, first the definition, is a clinical syndrome resulting from the failure of the testes to produce physiological levels of testosterone and a normal number of zoa caused by the disruption of one or more levels in the hypothalamic pituitary axis. We know that we can classify it traditionally as a primary, as secondary, or mixed form. But in the real practice, we know that this classification is not always possible, and we can happen to see very wide clinical spectrums. What happens across lifespan? We know from the longitudinal studies, like the Baltimore longitudinal study of aging, that testosterone across the lifespan is slowly decreasing at the rate of around 1.1 nanomole per liter per year. And this is confirmed from other samples like the New Mexico aging process study. We know that this is due to a reduction of testosterone levels and an increase of sex hormone binding globulin, therefore resulting in a reduction of free testosterone, as well as an increase of gonadotropin, LH, and FSH from the pituitary side. Also from prospective studies, so with more evaluation over time, we know and we can confirm that physiologically levels of testosterone are declining over time and with age. And we can see it clearly from the graph derived from the Massachusetts male ESE study. And we know that this is also paralleling the decline of the fertility and the overall, let's say, quality of semen of male production. But what is important that we learned from the study is that risk factors, and so the theory of the parallel tracks, are able to change the decline. And we can see in the figure how clearly patients with comorbidities, they are, or not apparently healthy, they have a steeper and faster decrease of testosterone levels. And of course, obesity is among the main comorbidities involved. This was also confirmed in This was also confirmed in the largest European study, where over 3,000 participants were enrolled with age over 40 years old. And at 2 times point evaluation, we know that we observed a change in testosterone levels. And this change was as high in amplitude as the numbers of comorbidities present in the population. Obviously, again, as we said, obesity seemed to play a key role. Indeed, if we watch at the 2 graphs on top, in green, we can see the normal BMI subjects decline and how it changes in the blue, in the overweight, and in the red, in the obese subject. And similarly, the decline of free testosterone and mean testosterone as there is an increase in weight on the lower graphs. The dimension of the problem is really important, and in this beautiful epidemiological study, so meta-analysis made and published in the European Journal of Endocrinology, we know that around 40% of subjects with obesity can be diagnosed with hypogonadism. And since the fact that obesity is nowadays driving a public health crisis, we need to consider these numbers. And as Eleni said in the introduction, this is a really important public health problem for the years to come. If we look at what kind of hypogonadism, according to the classification that we previously described, is occurring in obese subjects, we can see that according to BMI and waist circumference, the most of the subjects in this group are affected by a form of secondary hypogonadism. But as I mentioned, it's never clearly on the same, on one specific classification, but rather mixed conditions that occur at the same time. But this is happening why? We can see the same thing also occurring in the female. Indeed, we know that insulin, leptin, adiponectin are all hormones that are involved in signaling pathways that can influence the axis as a mirror of a nutritional state. Indeed, we know that leptin can act on GnRH pulsatility as well as directly on the steroidogenesis on the ovaries. Similarly, what happens in the testis is that we have an increase of adipose tissue, so an adipose tissue expansion, which leads to dysfunctional adipocytes, which increase the production of leptin as well as pro-inflammatory cytokines, which act at a higher level as an inhibitory role on key peptinergic neurons of the hypothalamus, and so influencing the GnRH pulsatility and therefore driving through a decrease of gonadotropin. This will act directly on gonadotropin receptors in the testes, especially if we consider testosterone production on the Leydig cells, where LH will be reduced and the receptor will be understimulated. Similarly, we know that leptin receptors will be able to influence negatively the activation of the STAR, so the steroidogenic machinery in the Leydig cells. Therefore, this will result overall in a reduction of testosterone secretion and in a vicious circle that leads from obesity to hypogonadism and back to hypogonadism, favoring again obesity and dysmetabolism. This situation led to the need to identify specific conditions, so the form of a functional hypogonadism, which now has specific society guidelines. As we can see, this one from the European Academy of Andrology, published in 2020. And we know that this clinical condition is described as the coexistence of androgen deficiency-like features and low serum testosterone concentration without the presence of any specific axis pathology or specific condition which suppresses the HPT axis. The community prevalence is really variable according to studies, but it's estimated between 2 and 12%. So we can roughly say that 1 in 10 men in the group of hypogonadism has this condition. Italian Society of Andrology and Sexual Medicine has also released a document, a consensus statement on this condition, and we can say that the definition clearly overlaps with what's previously stated. What is important that in the definition context, this document says that it often occurs in middle-aged and older men, and the comorbidities are key. And of course, obesity is mentioned among the main comorbidities. So what do we have to do to establish a diagnosis of hypogonadism? Obviously, we need to start from the clinical side. So signs and symptoms of hypogonadism. We know that the main signs involved can be low libido, reduced morning erections, erectile dysfunction, and general symptoms such as fatigue or decreased energy during the day, as well as sadness. So we start measuring total testosterone. When we find testosterone below 12 nanomole per liter, we also need to check on LH levels. And these suggestion from these consensus is to rely on 9.4 units per liter of LH to distinguish between normal gonadotropin levels rather than increased LH levels. Obviously, we need then to calculate free testosterone using SHBG, sex hormone binding globulin, because we know that direct measurement of free testosterone is not reliable with the commonly with the kit, commercial kits, and so we need to rely on Vermeulen's formula to calculate it. So we can clearly distinguish the presence of either secondary or primary hypogonadism, and in this case, consider treatment. On the other hand, when testosterone is above 12 nanomole per liter, it's more likely that we are not in the situation of, let's say, hypogonadism, but also there are certain situations where we have a compensated primary hypogonadism with an increase of LH, indeed compensating deficitary testis production. Remember, 2 serum testosterone measurements are necessary, and we don't have to forget about the physical examination, which is still important. And so we need to measure testicular volume with this instrument, which is called orchidometer. And so don't forget about this. So after we establish diagnosis, where do we go? Treat weight lowering before, so we treat obesity, or should we start from testosterone replacement? I will start from testosterone replacement and tell you that the TRT has some effects on body composition. Indeed, if it's neutral on weight, we know that it's favorable on body composition. So it reduces fat mass and it increases lean mass. It has positive effect on glycometabolic profile, so fasting glycemia and HOMA index, but neutral effect on lipid profile and neutral effect on blood pressure. This according to a meta-analysis studies published on the European Journal in 2016. Also, if we look at what happens in type 2 diabetes subjects, we know again that while BMI is not changing, body composition is, as well as we can see an improvement of glycometabolic parameters. So importantly, we know that testosterone from recently published trials is also able to prevent the evolution of prediabetes to diabetes and to reverse diabetes in the early stage. In this double-blind randomized controlled trial, we see that administration of testosterone, and in this case, I didn't state replacement because some of these men were not actually hypogonadal as we consider diagnosing it in the context of below 12 nanomole per liter. So actually testosterone treatment is able to improve glycometabolic parameters also in borderline testosterone men. What is complicated now is that there is no consensus among guidelines, and on one side, for example, Australian guidelines advise against the treatment of organic hypogonadism, of not organic hypogonadism, so the functional one, while others are more in the middle. We can see the British suggesting how men with testosterone below 8 nanomole liters usually require testosterone, but those in the borderline area, 8, 12 nanomole per liter, may require a trial. So it's not a clear position. I will stick in this case with Italian guidelines that recommend testosterone replacement to improve body composition. And it also suggests to improve fasting and glycemic, post-load glycemic control, and therefore the risk of developing type 2 diabetes. No recommendation, so there is a suggestion not to consider dyslipidemia rather than glycated hemoglobin as targets to be improved during testosterone replacement, but also waste circumference as a marker of visceral adiposity. So the bad fat tissue is to be considered. Let's keep calm because testosterone replacement is safe, is administered in the proper way, and data from the cardiovascular safety and testosterone replacement are clear. This is New England 2023. We know that testosterone gel is correctly administered and is safe from cardiovascular and oncological point of view as concerns prostate cancer. On the other side, we know that the landscape of obesity treatment is widely changing, and if lifestyle modification can only achieve 3% of weight loss on average, we know that pharmacological add-on can improve very much this, and we need to consider the opportunities offered from every option that we have. So if the diet around the average loss of 10 kilograms considers to improve around 2.5 nanomole liters testosterone, we know that we can achieve even more with very low calories ketogenic diet. So the effect on body weight is even more important. And we know, on the other hand, that we have medications such as GLP-1 receptor agonists that can significantly impact on gonadal axis. In this case, this original study from Giagulli, an Italian group, that showed that body weight improvement on the left in blue, you can see increases in the group with metformin, testosterone, and liraglutide, as well as a higher increase of serum testosterone levels, as well as an improvement of erectile function as assessed by ESE, so International Index of Erectile Function. But there are also some future perspectives that we need to consider. We know that some new medications are now on the market, and we know that, for example, with higher dosage semaglutide, we can achieve up to 11% weight loss and a sustained weight loss up to 68 weeks. Similarly, we know that we are going to soon be able to prescribe tirzepatide, and we know that the effect on both glycosylated hemoglobin, but it's not our focus in this moment, but on weight of tirzepatide at 10 milligram weekly and 15 milligram weekly dosage is significantly stronger than what we achieve with other medications. So these are my take-home messages. We need to remember that obesity is a disruptor of male gonadal axis, and this results in 40% prevalence of hypogonadism. The identification of secondary hypogonadism due to obesity is really easy and requires symptoms and the determination of low T levels. Testosterone replacement can bring beneficial metabolic and ponderal effects and is a safe treatment which should be offered especially to men with symptoms of hypogonadism, but also fat loss is really key to restore the physiology of function of hypothalamic pituitary gonadal axis, and we should intensively pursue it with new agents. I want to thank you for your attention, and I will stick around for the questions.
Thank you, Walter, for this outstanding talk. And now I will ask Eleni to announce our next speaker.